statistics of cervical cancer in Jamaica, the death rate and the infection rate, and presenting that information to the Minister of Health to see if I'm Dr. Morgan. I'm a family nurse practitioner. Welcome to Health Talk. Today I'll be talking about type 2 diabetes. And as you already know, that I use my space to discuss medical conditions that are affecting people. Type 2 diabetes is a very challenging disease for anyone to live with. I have a strong family history of type 2 diabetes. As a provider, it's very challenging to manage this condition, not because of the cost for the medication, but because of patients' inability to be compliant with their treatment. So I will start off by talking about what is type 2 diabetes, how it happens. It's an endocrine condition which affects people because their body is no longer able to process glucose, to process carbs, actually. So when you eat a nice rich meal in carbs, your pancreas secretes insulin, and that insulin is supposed to take that glucose, which is the end product of carbohydrate, and transport it from the bloodstream to the cells, where the cells use this glucose for energy. So when you are diabetic, it means that your pancreas, the B cells of the pancreas is no longer working effectively to do that conversion that I just explained, or you could be overweight and you have excess adipose tissue, which results in insulin resistance. So while the glucose is in your system, your fat cells pretty much are blocking the uptake of that glucose. So your body can't really utilize glucose well. And that is why when we stick your finger and we do your glucose level or your A1C, the glucose level is high because all of that glucose is sitting in your bloodstream and it should actually be utilized by the cells. So what do we do in a case like this? First, I just want to differentiate type 2 diabetes from type 1 diabetes because a lot of people don't know. They think that diabetes is just one big condition under one umbrella. Type 1 diabetes occurs as a result of the pancreas not making insulin. So you have to be on insulin as your management. So it's pretty much insulin replacement. For a person with type 2 diabetes, it's different. Your body produces insulin, but it might not produce enough. And as I explained before, insulin resistance blocks the whole process of glucose uptake. So we put our patients who have type 2 diabetes on oral hypoglycemic agents. There are now some new injectables, and these medications, you inject them once a week, and that will help to keep the glucose level down, as well as allow you to lose weight, to keep everything under control. But for most part, the management is pretty much with pills. Hemoglobin A1C is used to diagnose diabetes. It is the amount of glucose bound to your blood over a 3-month period. A1C should be below 5.7. 5.7 to 6.4 is considered as prediabetes. That means you have impaired glucose metabolism. An A1C of 6.5 confirms diabetes. Once you start management, your goal is to maintain an A1C below 7, and this is with medication, diet, and exercise. Most of my patients are diagnosed with an A1C of 14. So let me talk about the A1C a little bit. Hemoglobin A1C is a blood test that we do, and it measures how much glucose is bound to your blood over a 3-month period. And that is why when you're diabetic and you go to the doctor every 3 months, they need to get a new test to see what your numbers are. That number, your hemoglobin A1C, should be under 5.7. If it is 5.7 to 6.4, that means that you have prediabetes, and this is impaired glucose metabolism. Your body is not processing carbs the way it should. If your A1C is 6.5, type 2 diabetes is confirmed. Once it's confirmed, the goal is to keep it under 7. Because I operate a nonprofit low-income clinic, most of my patients do not have insurance. As a result of that, they do not go to the doctor. They might have symptoms of diabetes, but they just never thought about it. They are sometimes in denial until they end up in the hospital on a ventilator, some of them in a coma. And when they get out, they will come and see me because they need a doctor and they do not have insurance. A lot of doctors will not accept patients who do not have insurance, no matter what. And that's another topic for another time. So my purpose, my passion is to help these patients who do not have insurance or do not know that they can actually find these clinics to walk into to get help. So when they come to me, they're in a pretty bad state. I just explained the A1C ranges to you. My patients, when they come to me, their A1C is 14, 13, 15, and sometimes no reading. My A1C machine that I have in office, if it is over 15, there's no reading, I get an error message. So I get a lot of those error messages. So once a patient comes to me at 13, they really should be on insulin, but these patients do not want to take insulin. And a part of, working with patients, I try to work with the patient because I want compliance. It's not about what I can prescribe. I can prescribe anything. I can write a prescription for anything and send it to the pharmacy, but is the patient going to take it? So I work with the patient, try to be upfront, and I want them to be honest with me, and we're on the same page. So I usually prescribe oral hypoglycemic agents for these patients outside of the guideline, and I'm going to explain to you why I do that. One, I gain compliance from the patient. It will be more than one oral medication, but at least, we're getting there. Two, in America, insulin is available in the pharmacy without a prescription. So I have few patients who I put on insulin, and once they realize that that medication is over the counter, that 70/30 is over the counter without a prescription, whatever dose I start the patient on, when they had that high number, they just go back to the pharmacy and just buy more medication, buy more insulin, and they remain on that, and they do their own titration themselves. So they're not managed; they're managing themselves. So their labs are not done because they don't have any money. They're trying to cut out the doctor's visit, and my office visit is only $60. So they try to cut out the middleman and just go directly to the pharmacy, get this medication without a prescription, and they give it to themselves. So their blood pressure is not being managed, and their cholesterol levels are not being checked, and there's no way to see if their kidney is working fine or not. We just don't know anything about them. There are a lot of people in America right now just going to the pharmacy, buying insulin, taking it because they know that they're diabetic, without any form of medical management. So that is one of the reasons why I'm hesitant in prescribing insulin, because the patient's really not being managed. And they try not to give too much because they know the dangers of insulin. So as a result of that, they undertreat. And then there's no labs, so you don't know if they are having kidney impairment. You don't know what their cholesterol is. So this brings me to talk about the complications of diabetes. When we are managing diabetes, it's not about just prescribing a diabetes medication. You will notice that when you have diabetes and you go to your doctor, you're left there with probably about 4 different medications. One set of medication is for your A1C. That's to bring down your glucose level and to manage the diabetes. Another one is going to be for your blood pressure if you have hypertension. And even if you are not hypertensive, there is a set of medication called ACE inhibitor. They're used to treat blood pressure, but they're also used to protect the kidneys of diabetic patients from the diabetes. And one of the complications of diabetes is diabetes nephropathy, where the kidney starts spilling protein. And if that continues to happen, very soon that patient will be on a dialysis machine. So when we're managing diabetes, we're pretty much preventing the complications of diabetes, in addition to keeping the glucose under control. Once the glucose is under control, the risk of those complications will be less. So the complications of diabetes, number one, your stroke. And how do you get your stroke? your blood vessel starts to change, a condition called atherosclerosis, where the blood vessels get hard, and then you start building up plaque on the walls of those blood vessels. Then in addition to your high cholesterol, so that will increase your risk of stroke. A lot of your glucose level is high, so that means your blood is not really flowing that nicely. It has a lot of sugar in there, so your blood is thick and you can clot, and you can end up forming a clot. That clot can break off, go into the brain, block a blood vessel. There's no perfusion to the brain, then you will end up with a stroke. The next thing is your heart attack. The same mechanism that gives you a stroke also gives you a heart attack. Blood vessel either blocked with plaques, and or you get a clot, goes to the heart, or there's no perfusion to a part of the heart, you have your heart attack. Then the next complication is your eyes. The same mechanism happens to the blood vessels in the eyes, and you end up with a condition called diabetic retinopathy, and that can lead to blurred vision. You can bleed behind the eyes, and you can get blind. And that is why when we're managing diabetes, we have these patients go get their eyes checked once a year to see if there's any bleeding behind the eyes. And that patients with diabetes also develop cataract as well, eventually, if they're not, managing themselves well. Your next complication is your diabetes nephropathy. I just explained a little bit about it, about the kidney starts spilling protein, and then the kidney functions decline over time, a slow progressive decline in your kidney function, and then you get on a dialysis machine, and that's usually for life once you end up with chronic renal failure. The next complication of diabetes is diabetes peripheral neuropathy, in which the blood vessels, the nerves and blood vessels and the nerves in the feet, they're impacted, and there's poor circulation in the legs, and there's pins and needle sensation and pain. Diabetes affects major organs such as the blood vessels, the brain, the heart, the feet, and there's your leg ulcer, the kidneys, and of course your eyes. But the chances of it healing well is very, very slim, and you can end up with a bad diabetic ulcer, and that's how people get their amputation when they're diabetic. So when we're managing diabetes, it's not just prescribing a pill to lower the glucose. If you can look at your A1C and your glucose level and you see how high those are, you can physically see that with your eyes, but you physically can't see inside of your body the changes that are taking place as a result of your high glucose level. And that is why it's very important for you to follow up with your doctor and to keep on your medication, be compliant with your medication, and that will help to prevent these complications. And as I talk about the number one complication, which is a stroke, recently I had a patient who also had a stroke, and he didn't do so bad. He only have like slight facial deformity. He didn't have any loss of function of the limbs. So I took my blood from him in my office, and I stick this patient like 6 times. And this is a patient who I usually take blood from every time he visits. And the needle was sitting in the vein, no blood returning. So I had to draw for a little old trick that I learned. I get a glove and I fill it with some warm water, and I use it to massage his vein to warm up the vein, warm up the blood inside there, because I suspect that his blood was too thick. And then I used 2 tourniquets instead of 1. And then there comes the blood, and it was flowing, sluggish, was thick, it was dark. And when I asked this patient if he's taking his aspirin, he said no. So he's on his way to get his second stroke. So I pretty much educate him, and I explain the importance of taking the aspirin. And hopefully that will help him to understand that if he doesn't comply with his medication, he will have another stroke. The mindset is to manage your diabetes in lowering the glucose level. And you might be on 1, 2, or 3 of those medications, depending on how high your glucose or your A1C level is. The next one is going to be your hypertension medication. If you're hypertensive, the ACE inhibitor. Even if you're not hypertensive, you will be on this medication, a small dose, to protect your kidneys from the diabetes, because this medication helps to prevent the spilling of protein from the kidneys and prevent you from going on a dialysis machine. That's why you're on that medication. The next medication is going to be your cholesterol medication, and that's going to keep your cholesterol level low because, a lot of fat, builds up inside those arteries, and you need that cholesterol medication to help to prevent your stroke. Even if you do not have high cholesterol, the guideline is that you take that cholesterol medication. Then the next medication going to be your blood thinner, which is your aspirin. It's very important for you to take that baby aspirin to keep the blood thin and flowing nicely, and that will reduce your risk of stroke. And then if you have any other issue like diabetic neuropathy, you might be on your gabapentin. That will help with that numbness and pain as well. So those are the medication that you are going to be on if you're diabetic. And the medication that you will be prescribed will also be based on affordability and based on what your insurance will cover. And there are tons of lovely diabetes medication out there, but some of them are so expensive that patients cannot afford them. And even if you have insurance determines which one they will cover. Right now, there are some nice medication that the patient can inject themselves once a week. And those medication can range from $1,000 to $1,500 per month for just one pen or 1 month supply with 4 pens. So that's what's happening in terms of managing diabetes. The good old faithful original medication like metformin, glimepiride, glyburide, Actos, they're still out there, and I use them a lot in my office because they're more affordable, but they're not the best medication. And it is heartbreaking to see that a patient blood sugar, patient A1C can go under control by prescribing certain medication that's so good. They work so well, but it all depends on where you work, and where you work will provide you with the insurance and what your insurance decide to cover. And that is pretty much the bottom line. The next thing we're going to talk about is managing your diabetes at home. That is a major, major part of you managing your diabetes. You can't manage diabetes by just taking medication alone. You have to change your diet. For me, I'm a Jamaican, and my diet consists of what I learned to eat culturally, starting as a child. We eat a lot of carbs, a lot of yam, banana, potato, rice, flour, and those are carbs, and that's not good for the body. That's like kind of overburdening yourself with carbs. So I only eat what I know to eat. So if I was diabetic, I will have to change that. So changing your diet doesn't start when you're going to prepare the meal. It starts when you're going to the supermarket. And you have to make an active decision to change how you eat. And you have to do that gradually, do that in increments by trying new food. Look for food that has a low glycemic index diet. Low glycemic index is anything under 60, and you will have to do some research and do that, or see a dietitian. My patients don't like the dietitian. They think that they're going to starve to death when they go to the dietitian because what they recommend is not enough. They don't think it's enough to give them, energy or make them feel satisfied. Fruits for diabetes, any berries will work. Blueberry, blackberry, strawberries, and these are healthier choices that has low glycemic index. This is a healthy diabetes diet. Sweet potatoes, basmati rice for diabetics, whole wheat, brown bread, and a good calorie chart will help